We are pleased to have Dr. Scott Bauer with us today. Dr. Bauer is an assistant professor with a dual appointment in medicine and urology from the University of California, San Francisco, and he's a recent K-12 alum. Dr. Bauer has a master's in epidemiology from Harvard School of Public Health. He then moved to the University of California, San Francisco for medical school, followed by a residency in internal medicine and primary care. Dr. Bauer's research focuses on geroscience, or the biology of aging. More specifically, he studies how various lifestyle factors and phenotypes that indicate accelerated biological aging are associated with lower urinary tract symptoms. So today he will discuss how we can leverage what we know about geroscience to improve our understanding of age-related lower urinary tract symptom risk factors and pathophysiology. So welcome, Dr. Scott Bauer.
Thank you, Lauren. I appreciate it. Nice to see many names I know and some that I don't as well. Let's see. And you already seen the title of my talk. The main point of this slide is for folks to have my contact information. I have developed a lot of really exciting collaborations from presenting to and discussing my research with CAIRIBU members in the past. And I'm always looking for new and exciting collaborations. I have some disclosures that aren't relevant to the materials I'm going over today. And for those of you that haven't heard me speak before, I always state my research mission, which is to help older adults with lower urinary tract symptoms by studying how aging mechanisms contribute to these common urologic symptoms. Here's a brief outline of what I'll be speaking about today. We'll talk about epidemiologic evidence for associations between lower urinary tract symptoms, or Lutz as I'll refer to it for the rest of this talk, and physiologic urogenital measures. We'll then review the epidemiologic evidence for Lutz and chronological aging. And then I will go over several projects looking at Lutz and phenotypic as well as functional aging, as well as future directions with a couple of exciting grants that were funded in the last few months. So most CAIRIBU members, or those that have seen me talk before, know what Lutz are, but for those of you that are newer, this is a heterogeneous syndrome of symptoms that occur when storing and voiding urine. I've listed the various types of symptoms older adults can develop in the white box on the right. And what's important to know is that Lutz affect most adults in their lifetime. Over 50% will report some degree of symptoms, and about a third will reach clinically significant or treatable threshold during their lifetime. However, Lutz have very heterogeneous manifestations and degree of bother as well as quality of life effects. Two individuals with the same frequency of symptoms can have very different ways in which these symptoms affect them and debilitate them. That also affects how they seek treatment. And what is not very well known is that urogenital changes with age are actually quite weakly correlated with symptoms. This includes prostate volume and urinary flow rate in men. It includes urodynamic assessments of bladder in older women and men. And I've taken this as evidence that the pathophysiology of age-related Lutz remains poorly understood. And we're going to dive a little bit deeper into that today. And that wouldn't be such a big deal if the medications that were targeting these mechanisms were benign. But our current first-line therapies, which target urogenital mechanisms, they specifically try to decrease Lutz frequency and are modestly effective at that. And they have really important side effects that in many older adults are prevent them from being able to receive any therapy at all. So taking a step back, why do I keep mentioning these urogenital mechanisms that are poorly associated with symptoms? So I'm going to primarily focus on male Lutz here, which and try to show you the evidence that measures of obstruction explain very little of Lutz severity in men in general, and this is likely even worse in older men. So in these two cohorts, what they did is they measured the prostate volume and peak urinary flow rate, as well as the AUA symptom index, which is the most common measure of Lut severity. And you can see that in terms of the amount of variability in the AUA score that is explained by prostate volume, it was 2 to 3%. So knowing someone's prostate volume gives you very minimal information about the severity of Lutz that they may report. And then if you measure their urinary flow rate, which is an even more accurate proxy or surrogate of bladder outlet obstruction due to BPH in men, depending on the population, best case scenario, it only explains 12% of variability in the AUASI, leaving 88% of the variability in Lut severity unexplained. And in this Berry study, only 1% of variability in the AUA score was explained by peak urinary flow rate. When using invasive urodynamics, the categorization of someone as obstructed, again, this is in men, obstructed, unclear, but maybe obstructed or unobstructed. These urodynamic categorizations similarly are extremely poor at distinguishing those who have Lutz and versus those who do not. So you can see here in the total AUASI column that those with urodynamically confirmed bladder outlet obstruction due to most likely BPH had a mean AUA score of 17.5, and those who had no obstruction had a mean AUA score of 17.2. So the ability of urodynamics to identify those with and without symptoms is extremely poor. And this is true both for voiding symptoms and storage symptoms as well. Now, moving over to women and looking at, again, bladder stability determined by urodynamics. Again, the AUA score is very similar between those who have stable versus unstable bladder phenotypes. And perhaps, there's a statistically significant difference in storage subscores, but when you think about what are clinically meaningful differences in AUA score, a 2-point difference is quite minimal. So again, urodynamics are very poor predictors of Lut severity. So this has been synthesized quite well in this really nice JAMA rational clinical examination, which asks, can we use the AUA symptom index to identify men who have bladder outlet obstruction? And what they found was that an AUA score of 20 or greater, indicating severe Lutz, had only a sensitivity of 41%. So it only detected 41% of people who had urodynamic confirmed bladder outlet obstruction, and had a false positive rate of 29%. For those that are familiar with likelihood ratios, it basically means a positive likelihood ratio of 1.5 means that if someone has a AUA score of 20 or greater, you're only 50% more sure that they have bladder outlet obstruction compared to knowing that information compared to not knowing that information, which is not actually that helpful. And similarly, knowing that they have a low AUA score only makes them 18% less likely to have bladder outlet obstruction. Again, indicating that the bladder outlet obstruction is contributing very little to men's AUA symptom index. And so some might say, okay, maybe there's individual symptoms that are more sensitive to bladder outlet obstruction in men. And in this pooled analysis, it turns out that no single symptom had a likelihood ratio that did not include a confidence interval with 1, which basically means that knowing the presence of any single urinary symptom did not increase the likelihood of a man having bladder outlet obstruction. So with this information, you may not be surprised to find out that urodynamics, the measuring of urodynamics, don't improve Lutz outcomes. And this has been demonstrated in multiple randomized controlled trials. I'm now taking a step back to both data from both women and men. And that's why in the guidelines they're not recommended for individuals who present with quote unquote uncomplicated LUTs. This has been tested more recently in men with a non-inferiority randomized controlled trial in 800 men with bothersome LUTs treated by a urologist. And to break down this somewhat complicated figure, on the x-axis is time, on the y-axis is the AUASI or the IPSS, those are synonymous. And those and they stratified by whether or not you had received surgery. So dotted lines are those who received surgery and solid lines are those who did not. And the main point is that the orange and blue lines are nearly identical. So which means that if a urologist had access to urodynamic information, that did not change their ability to improve symptoms in men that they were treating. And as a clinician, that informs me that you're not actually learning anything from the urodynamics, and that understanding these physiologic measures also does not change what you're going to do for them. And if it was true that if the urodynamics changes were driving symptoms, then knowing what the urodynamics were would be very helpful. And so, again, this is evidence that our framework for LUTs in both women and men, but I've given mostly data for men, I think is missing the mark. So all of that to say, led me to think more broadly of LUTs risk factors and what are the strongest risk factors that maybe haven't been investigated quite thoroughly enough. And chronological age in both women and men is the single strongest LUTs risk factor. These are cross-sectional survey data from 4 countries: Netherlands, France, Republic of Korea, and one that I'm forgetting. And you can see that the prevalence of moderate to severe LUTs increases quite dramatically with age in both women and men. And because you can't stop time and you can't stop chronological aging from occurring, this has kind of just been ignored for a very long time. This was just a kind of assumed fact about LUTs. But as you will see, we're understanding more and more about aging and the mechanisms of aging and how aging affects chronic diseases. And so I thought that this maybe could be leveraged to understand age-related LUTs better in both women and men. Of course, it's not as simple as LUTs increases with age in both women and men at the same rate. When you start to dive down into Lut subtypes, you can see some really important differences. So these are 2 graphs showing overactive bladder, or OAB, with and without incontinence. And you can see that on the left, dotted lines are women and solid lines is men, and that overactive bladder with incontinence increases most dramatically in women, and it increases in men as well, but not quite as dramatically. But then when you look at overactive bladder without incontinence, that you have a more dramatic increase with age among men, and you have a more modest increase among women. And this has motivated me to really think of considering associations with and without incontinence, particularly when I'm looking for sex differences, and to make sure that I think more holistically that overactive bladder without incontinence may be the more prominent aging phenotype of LUTs in men, but symptoms LUTs with incontinence may be the more prominent phenotype in women. And so part of why a big motivating factor of a lot of my work is what happened when urinary incontinence became accepted very broadly as a geriatric syndrome. This is from one of the seminal papers by Sharon Inouye. And the main point of her study was that these geriatric syndromes tend to travel together, that they share many risk factors. I extracted some of them from the paper. They included older age, cognitive impairment, functional impairment, and mobility impairment. And what happened when urinary incontinence was categorized as a geriatric syndrome was that it moved out of the urologic and urogynecologic space, research and clinical space, and there became multidisciplinary teams researching and treating this condition. And I think that it has led to some really exciting improvements in our understanding of urinary incontinence pathophysiology, as well as interventions that often are multifactorial and both improve urinary incontinence as well as these other geriatric syndromes that are so important to older adults. And I'm hoping that if we, urinary incontinence is a very narrow subtype of Lutz, and part of my research program is trying to argue that Lutz in general should be considered a geriatric syndrome, and that we should be thinking about the pathophysiology of Lutz using a much broader lens. So I already have somewhat mentioned this, but there are several specific advantages to an aging-focused approach to Lutz in older adults. It acknowledges the inherent multifactorial and overlapping nature of chronic diseases and syndromes of aging. These diseases and syndromes don't occur by themselves. And so both in terms of pathophysiology, if you focus just on your organ of interest, you're going to miss a lot of contributors to disability and symptom burden, and your treatments aren't going to work that well. And I think that's what we're seeing when we, in terms of Lutz treatments for older women and men. It facilitates the identification and targeting of shared upstream age-related Lutz mechanisms. And so if there is a biological mechanism that is contributing to both Lutz as an age-related disease, but also mobility impairment and falls and dementia, if you target the upstream mechanism, you're going to have beneficial effects on both Lutz and the other aging syndromes that tend to co-occur with it. And clearly that, older adults are going to derive greater benefit when our interventions are improving the array of age-related diseases that they have, rather than specifically targeting narrowly, urogenital dysfunction. And then lastly, it's an opportunity to refocus on clinical outcomes that are of greatest interest and importance to older adults with Lutz. If you look at what it takes to get a Lutz intervention approved by the FDA currently, it's focused on the frequency of symptoms. And we'll go over a little bit later, but the frequency of symptoms is potentially not the most important, or is one of many different consequences of Lutz in older adults. And if we only study mechanisms of Lutz frequency and not Lutz disability and Lutz bother, then our interventions that target those mechanisms will only affect Lutz frequency, but they won't affect the broader picture. And so if Lutz are associated with all these poor quality of life outcomes that everyone mentions in their introduction section of their manuscripts and their grants, then our interventions should be affecting those quality of life impacts as well. And it is disappointing to see sometimes that Lutz interventions get approved because they affect frequency but not bother or broader quality of life outcomes. And I think that an aging focused framework has the opportunity to have much greater quality of life impacts for the reasons that I've outlined before. So now into my one alternative aging focused framework that I've been using, and I welcome input from anybody on this. I adapted it from, it's called the metrics of aging, and these are have been described by Dr. Luigi Ferrucci at the NIA in the Baltimore Longitudinal Study of Aging. And to kind of walk those who have not heard of this through, biological aging occurs at the molecular, cellular, and intracellular levels. And underneath biological aging, I've shown this classic figure from the Hallmarks of Aging paper by Lopez and Oaten. We haven't really tested association between biomarkers of biological aging and Lutz, so I don't have much to report in that box. But when the redundancies and resilience mechanisms of biological aging are exhausted, it manifests as phenotypic aging, which are changes in body composition, energetics, homeostatic control, and neuronal function. And underneath phenotypic aging, I've listed associations between phenotypic aging measures and Lutz that have been reported mostly by other investigators, but primarily using cross-sectional data. And so one thing that my team has been working on is to try to increase the robustness of these studies by repeating them using longitudinal study designs. And in particular, decreased muscle mass is one that has been of interest to us recently. And again, once phenotypic aging crosses a certain threshold, similar to biological aging, it starts to interfere with physical and cognitive performance and ability to complete activities of daily living, which is categorized as functional aging. Again, I've listed functional aging measures that have been shown to be associated with Lutz, and some that our team is investigating actively right now, including fatigability and cognitive decline. And so my overall research goal is to map these associations of biological, phenotypic, and functional aging measures with Lutz, and to understand these relationships in order to kind of fill out this aging-focused framework. And the reason being is that there's a lot of really exciting interventions coming down the line that target biological aging in order to improve functional aging outcomes. And I think that, hitching our bandwagon to this very exciting development in the aging research field could lead to a whole slew of new interventions for age-related Lutz. Broadly speaking, my methodologic approach to addressing these questions is using large epidemiologic data sets that have both repeated measurements of these metrics of aging as well as Lutz severity and bother. I've been using secondary data analyses of clinical trials more recently, and there are some very exciting anti-aging interventions that I'm hoping to add Lutz measures to in order to determine whether or not targeting biological aging can indeed prevent or treat age-related Lutz. And I showed you the data on how Lutz in both women and men increases with age. Perhaps there are overlapping or similar mechanisms to age-related Lutz in women and men, and almost certainly there are differences. But you won't be able to determine that if you don't have studies that include both sexes and assess Lutz using the same tool so that you can start to identify these similarities and differences. And then my analytic approach is longitudinal modeling of metrics of aging and Lutz. So I'm going to shift now to going over a few key studies that our group has conducted over the last couple of years. And then we will wrap up with where this research has led. So to start, I thought I'd start with a common risk factor for age-related Lutz in men that was largely based on cross-sectional studies, some longitudinal studies in younger men, but had never been robustly tested in older men. And I wanted to know whether or not changes in adiposity were associated with concurrent changes in Lutz severity in older men. This would be helpful to know because if older men who are obese have Lutz, and we recommend that they lose weight or decrease their fat mass, I wanted to know would their Lutz get better. And I have hypothesized based on data in women, as well as some of this other cross-sectional data that I mentioned, that it would. And this is going to be a relatively brief one, but to tell you about the methods, it was about 6,000 community-dwelling men who were 65 or older, who weren't missing the key predictor and outcome data. They were followed for 9 years. Our exposure was adiposity assessed at 3 visits, and we defined adiposity 3 different ways. DEXA, which is a basically low radiation approach, It's very good at distinguishing bone from other types of tissue and also identifying fat mass. You can also use DEXA to identify specifically adipose tissue in the abdominal area or visceral adipose tissue area. So we used that, and then also BMI, a very common clinical measure of adiposity. The outcome was change in AU-ASI score assessed at 4 visits. And we used linear mixed models adjusted for demographics, height, except in BMI models for obvious reasons, health-related behaviors, comorbidities, as well as baseline AU-ASI. And so the punchline of this analysis was that men who have changes in their adiposity, age 65 or older, do not have any improvements in their Lutz severity. This is true both for baseline adiposity as well as time updated or within person change in adiposity. And that was true across all 3 adiposity measures. The one exception being perhaps baseline adiposity, but this is of all of these measures, this is the most confounded coefficient because you're comparing men who have different BMIs, and they have different BMIs for various reasons. But when those men changed their BMI over time, over the decade, that change was not related to a change in Lutz. And so I've taken this to be evidence that that changing one's BMI after age 65 will not change their risk of Lutz. So conclusions from this study were that change in adiposity is not associated, sorry for the typo there, with change in Lutz severity among older men. Cross-sectional studies of Lutz risk factors need to be confirmed using robust longitudinal methods before testing interventions in human clinical trials. This is particularly true for older adults. I think this study is a really great example of why, 1, null studies are really important to publish, and 2, that cross-sectional studies need to be confirmed using the longitudinal methods that my team prefers. And I think it also suggests that Lutz risk factors and mechanisms may differ between younger and older adults, and that perhaps a multi-system age-related Lutz mechanisms need to be investigated more thoroughly, rather than the risk factors and mechanisms that we have kind of depended on thus far. So this, if metabolic or other common risk factors for Lutz don't appear to be associated with Lutz severity in older men, it led me to start thinking of what are kind of classic functional aging measures that perhaps might support the idea of using this more aging-focused framework. And frailty came to mind as a good one to start with. So I asked the question, is Lutz associated with frailty in older men? And I hypothesized that greater Lutz severity would be independently associated with a higher odds of phenotypic frailty in this population. And in the top right, you'll see in my slides, I've kind of circled the part of this framework that these studies are referring to. So again, I used data from the same osteoporotic fractures in men, or Mr. Oss study, about 6,000 men. The exposure was AU-ASI score, and we used the common clinical categories of none, moderate, and severe Lutz based on the AUA score. We used previously published storage and voiding subscores to see if there was a Lutz subtype that might be more or less strongly associated with frailty. And then the outcome was a phenotypic frailty score that has been previously published using Mr. Oss data. Effectively, there are 5 components that are assessed using objective measures of lean body mass, grip strength, and gait speed, as well as self-reported energy levels and physical activity. And men were then classified depending on how many criteria they met. 0 criteria, they were categorized as robust, pre-fail or intermediate if they met 1 to 2 criteria, and they were considered frail if they met 3 or more. And then we use multinomial logistic regression to look at the association between AU-ASI score and phenotypic frailty score. The results of this study were that odds of frailty increased with increasing Lutz severity. The figure on the right, the main takeaway is that this is the prevalence of frailty. And you can see that among men who were with none or mild Lutz, about 7 or 8% were frail, and that increased steadily with increasing Lutz severity, all the way up to 18 to 19% among men with severe Lutz. And as one would expect, the prevalence of men who are robust went down with increasing Lutz severity, and the prevalence of pre-frailty increased slightly. Now, we want to make sure this was independent of known risk factors for frailty. So we adjusted for chronological age, demographics, health-related behaviors, and comorbidities. And once we did that, the odds of frailty were 41% higher among those with moderate Lutz compared to those with none or mild Lutz. And the odds of frailty were 2.5 times higher among those with severe Lutz compared to none to mild Lutz. Interestingly, these were consistent across storage and voiding subscores. And we did a large number of sensitivity analyses demonstrating that this was independent of Lutz medications, multimorbidity, that this was not due to increasing urinary incontinence among men with severe Lutz, as well as independent of cognitive impairment. We excluded those who had those conditions. And so the main conclusions, particularly for this group of this study, were that older men with greater Lutz severity are more likely to demonstrate phenotypic frailty, that both storage and voiding Lutz were associated with frailty, and that these findings don't really fit with this existing urogenital focused framework that we've used for so long. If Lutz severity was being driven by, say, an enlarged prostate due to Bph and decreased urinary flow rate, we wouldn't expect men who had Lutz due to Bph to have such strong association, such a high burden of frailty. And it really suggests that a different framework is potentially needed. So that motivated me to take this further and look at the same association, but longitudinally. So I then asked, is increasing phenotypic frailty associated with change in Lutz among older men who don't have Lutz at baseline? So is the development of Lutz occurring as men become more frail? So we then took the same prospective cohort, Mr. Ross study. We excluded all the men who already had Lutz. So we started with a nice clean cohort of men who have no Lutz or none to mild Lutz, and that was about 3,000 men. Again, there were 9 years of follow-up data. And in this case, that same phenotypic frailty score was used as this time as the exposure, and was assessed at 3 different visits. We separately looked at baseline frailty, which, if you're going to look at associations between baseline measures, that's associations between different people who have different frailty scores. And we also looked at time updated, which represents within person differences or changes. So as a single man became more frail, did that same man develop worsening Lutz? The outcome was change in AUASI score assessed at 4 visits. And again, we use linear mixed models, adjusting for confounders and baseline AUASI score. And what we found was that frailty is indeed associated with worsening Lutz. So I mentioned these 2 different coefficients, one for baseline frailty and one for which represents between person differences. So do 2 different men, one who's frail, one who's not frail, have different changes in Lutz? And the answer is no, or in some cases they even have less Lutz. But now within a person, if their frailty is getting worse over the 9 years of follow-up, is that same person's Lutz severity getting worse? And the answer is yes. A change in AUASI score was about 0.58 points higher per additional frailty criterion met. And this was adjusting for other things that might have happened to that same man during follow-up, such as developing a new comorbidity like diabetes or stroke or Parkinson's disease. Also adjusting for the fact that their age is going to increase over time as well. And when we then looked at storage and voiding Lutz, again there was no difference between the two, suggesting that within person changes in frailty contribute similarly to both storage and voiding Lutz. So conclusions of this study were that phenotypic frailty and Lutz severity increase concurrently among individual older men who do not have Lutz at baseline. And this really points to, again, cross-sectional studies are limited, but these longitudinal studies can provide relatively strong evidence for a shared underlying mechanism. And currently, none of our Lutz interventions in men target such a mechanism. There, as far as I know, alpha blockers and 5-alpha reductase inhibitors do not prevent frailty. And so this really suggested that these underlying mechanisms needed to be identified and could potentially be targeted for new Lutz treatments in men. So one problem, though, with using the Mr. Oss study is that it's a community dwelling cohort. And so I did not have any measures of bladder outlet obstruction or surrogates of bladder outlet obstruction. And so I racked my brain to try to find a data source that did. And it ended up being a clinical trial, the landmark MTOPS trial, or Medical Therapy of Prostatic Symptoms, which was back in the 2000s. And I used this data set to answer the question, is frailty associated with clinical Bph progression in older men? And my hypothesis was that a greater cumulative deficit frailty index score would be associated with an increased risk of clinical Bph progression, and that this association would be modified by drug treatment arm. So the MTOPS trial was a 4-arm randomized control trial. Men were randomized to placebo, doxazosin, an alpha blocker, 5-alpha reductase inhibitor, finasteride, or combination therapy with both doxazosin and finasteride. These were all men who had been determined by a clinician to have what was suspected to be Bph and Lutz due to Bph. And the primary outcome was what was called at the time clinical Bph progression. That phrase has fallen out of favor, but and I'll tell you a little bit more about what that is in a second. There were 3,000 men who were enrolled. They were all over age 50, and they were followed for at least 4 years. The exposure, so I mentioned phenotypic frailty, which was had these 5 components, and depending on how many components you had, you were determined to be robust, pre-frail, or frail. That's one way of thinking about frailty, a conceptual framework for frailty. An alternative conceptual framework for frailty is called cumulative deficit, which is as people become more frail, they accumulate all kinds of deficits. And rather than focusing on 5 kind of key ones, we should focus on all of those different deficits and see basically what percentage of them a person has developed. And once someone has accumulated a certain number of deficits or percentage of deficits, they are highly likely to be frail. So it's a different way of getting at the same general concept of frailty. And so because of the data that was available at MTOPS, I created a cumulative deficit frailty index. It had a range of 0 to 1, and it was based on 68 items that were assessed at baseline in the MTOPS trial. This included the presence or absence of comorbidities, self-reported physical function, mood, as well as lab abnormalities. So if someone had labs that were outside of pre-specified normal range. I then used scores on this frailty index to categorize men as fit or robust, pre-frail, and frail using previously published thresholds. And then the outcome was this clinical Bph progression, which at the time was defined as a composite outcome of worsening Lutz, greater than 4-point increase in the AUASI, new urinary retention, new urinary incontinence, and then recurrent UTIs or new renal impairment or kidney disease. Those last 2 were exceedingly rare, didn't occur in any of the individuals in MTOPS. About 78% of the events were due to progression of Lutz. And I followed the same analytic approach as the original trial, which was a time to event analysis using log rank tests and Cox proportional hazard models. And to show you the results, this came out in JAMA Network Open a couple of weeks ago, what we found was that men who were frail, based on this deficit accumulation frailty index, had a much higher cumulative incidence of the composite outcome of clinical Bph progression compared to those who were pre-frail or robust. And when we separated out specifically lower urinary tract symptom progression, that the association was observed among these men as well. Now, this is not adjusting for any other factors. And as I mentioned, these were men who doctors suspected had BPH and that their Lutz were due to BPH. And that's what the drugs of this trial were targeting. They were trying to shrink the prostate. They were trying to relax the smooth muscle of the prostate. And so I wanted to know, was this association independent of bladder outlet obstruction surrogates, as well as other potential confounders? And so we generated models that adjusted for chronological age, demographics, several different surrogates of bladder outlet obstruction, including prostate volume, post-void residuals, maximum urinary flow rate, and then also other conditions that are known to be risk factors for Lutz progression, including BMI, as well as comorbidities. And what we found was that the frailty index was associated with the outcome of clinical Bph progression, but we saw statistically significant interactions between which treatment arm they were randomized to and this association. And somewhat surprisingly to me, what we found was that the association between frailty and clinical Bph progression was strongest among men who were receiving both finasteride and doxazocin, and as well as men who were receiving doxazocin alone. And so that was actually pretty surprising to me. The association between frailty and clinical Bph progression was weaker and actually not statistically significant among men who were receiving placebo, and it was borderline for finasteride alone. So conclusion from this study is that greater deficit accumulation frailty index scores are associated with greater risk of clinical Bph progression, independent of obstruction measures, and that this is particularly true among men who are receiving doxazocin with or without finasteride. Future studies should evaluate potential mechanisms of how frailty contributes to worsening Lutz, particularly in the setting of Bph drug therapy failure. I kind of conceptualize it as, once you take the prostate out of the picture, once you shrink it and relax the smooth muscle, frailty is really driving the majority of progression cases. And that's very different than how we've thought of it thus far. Right now, when I'm seeing a patient in primary care and they have progression of their Lutz despite combination therapy with 5-alpha reductase emitters and alpha blockers, I send them to a urologist to have a BPH surgery, because I think that their symptoms are progressing, or they're failing medical therapy. And man, does that mean that their BPH must be really severe. We should tackle it using something even more invasive. And I would say that this study suggests that maybe frailty is explaining more of those treatment failures, rather than the need for using a more invasive procedure to treat BPH. So I've talked a little slowly, so I'm going to go through this one relatively quickly, but it's an exciting study that was just accepted for publication in the Journal of American Geriatrics. If Lutz is indeed a geriatric syndrome that we should be considering more holistically using an aging-focused framework, then Lutz should predict other important geriatric outcomes. I mentioned that they co-occur frequently, and that the presence of one geriatric syndrome should predict the presence of another. And so I asked the question, again, in older men, is Lutz severity associated with incident functional limitations? I'm going to skip through my methods, and I'm going to get to the punchline, which was that greater Lutz severity was indeed associated with risk of new mobility and ADL, or activities of daily living limitations. So again, we saw an interaction with age, so that's why these results are stratified that way. But you can see here, these are men with relatively very low Lutz severity, an AUA score of 0 to 3, with increasing Lutz severity up to the highest quartile, which is a score of 13 or greater. And you can see that the risk, 2-year risk of a new mobility limitation really increases significantly with greater Lutz severity. We ran models, again, adjusting for confounders, and men who are in the 4th quartile of the AUA-SI score have 3 times the risk of a new mobility limitation in the next 2 years compared to men who are in the lowest quartile, confirming that the presence of Lutz is informing the risk of geriatric outcomes that really have nothing to do with the prostate or urogenital function, as far as we know. We then also did ADL, looked at risk of ADL limitations, activities of daily living. That includes ability to bathe yourself, clean your house, doing dishes. And again, there was a significant association, this time particularly observed among those in this middle age group, where greater Lutz severity was associated with higher risk of new limitations in the next 2 years of activities of daily living. Sorry, I went through that one relatively quickly, but I wanted to show that to you and get to where we are headed. Okay, so all of these were kind of preliminary studies that I've been working over the last couple of years. But what I really wanted to do was look at associations across all 3 metrics of aging in the same cohort in both women and men, and trying to determine multi-level associations with Lutz severity. And partially because I kept on seeing that people with Lutz, women and men with Lutz, have particularly difficulties with mobility, and mobility is largely driven by skeletal muscle health. I wanted to know whether age-related changes in skeletal muscle would be associated with Lutz in older adults. And to answer this question, we've been funded to add a Lutz questionnaire to the study of mobility, muscle mobility and aging, or SOMA. It's a prospective cohort that's currently enrolling almost 900 older adults, all age 70 or greater. They're recruiting older age individuals, 50-50 women and men, and at least 20% non-white individuals. They'll be followed for up to 4 years. And what's really exciting to me is that they are collecting really deep phenotyping on muscle measures, which include physical performance, MRIs of the entire body to determine muscle volume. They are using really state-of-the-art methods to identify muscle mass. And they are doing skeletal muscle biopsies to determine mitochondrial bioenergetics. And we've now added a Lutz questionnaire to this cohort, both at baseline as well as during all of the annual visits. And we'll be using the same analytic methods, except now instead of just looking at associations somewhat narrowly at one metric of aging, whether it's phenotypic aging or functional aging in Lutz, we're going to be able to look at multi-level relationships between skeletal muscle health, both biologically, the mitochondrial health, phenotypically, like how much muscle there is, or the volume of muscle, and functionally, because they have all these physical performance measures. And I think that this will really be a start to testing hypotheses using this aging framework that I've been advocating for. And I mentioned that I got a K76 from the NIA to fund that work. Lastly, I want to leave time for questions, so I'm going to describe this relatively quickly, which I received I also wanted to dive really deep into the relationship between biological aging and age-related Lutz. And one of the more promising avenues to look at this was mitochondria. And I wanted to know, what is the role of mitochondrial DNA mutations as well as mitochondrial dysfunction in male Lutz and Bph? And to do this work, we were very excited to receive a O'Brien Center Opportunity Pool Award. And to briefly tell you about our aims, in case you are interested in collaborating or providing input into this project. First, I don't think I have time to describe mitochondrial DNA to folks, But basically, mitochondrial DNA acquires mutations over time with aging. And because there are thousands and thousands of mitochondrial DNA molecules in a cell, each cell has a mixture of normal and mutated DNA, and that's called heteroplasmy. And that's considered a quantitative measure of mitochondrial DNA mutation burden. And we're going to look at the association between mitochondrial DNA heteroplasmy as well as copy number variation, which is basically the amount of mutated DNA with Lutz among older men in this very well characterized cohort of community dwelling older men. So that's aim 1, that's over here. The other aims 2 and 3, so as these DNA mutations accumulate, there are several regulators of mitochondrial homeostasis that prevent mitochondrial damage and dysfunction. One of these is called mitochondrial quality control and dynamics. And these basically mitochondrial homeostasis is an energy production is regulated by 2 opposing forces: the removal of damaged mitochondria or their components, and that's via mitophagy, and the addition of new proteins or lipids to existing mitochondria via mitochondriogenesis. And these 2 forces are highly dependent on mitochondrial fission and fusion proteins, which we can measure. And so in aims 2 and 3, we're going to be measuring key fission and fusion proteins. And we will also be looking at bioenergetics, which is basically the energy output of mitochondria in cells. And we're going to be doing this using tissue from Doug Strand's lab at UT Southwestern. Our second aim of the pooled award, we're going to look at both the pattern and the degree of differences in mitochondrial quality control and dynamic proteins, as well as bioenergetics in prostate and bladder tissue from Bph cases and age-matched controls, using a relatively small number of cases, but we're hoping that this will generate really exciting preliminary data. And then among men who have Bph, we're also going to look at these same measures to see if they're associated with Bph disease severity, using again blood, prostate, and bladder tissue from a larger group of men. I have lots of people to thank without whom this work absolutely would not be possible, as well as my more recent University of Wisconsin-Madison O'Brien Center collaborators, all the participants of the cohorts that I use, and of course my funders.